Hello and welcome to World Med School. My name is Dr. Brad Hare. I'm an associate professor of clinical medicine at the University of California in San Francisco. And in today's micro lecture, I'll be talking to you about the treatment of HIV in adults and adolescents. By the end of the talk, you will understand the goals of treatment with antiretroviral therapy, which I will refer to as ART. You'll discuss the risks and benefits of earlier initiation of ART, as well as the guidelines for ART initiation, both in the United States and globally. And finally, we'll highlight some of the patient-centered approaches that you will take when initiating antiretroviral treatment and discussing treatment adherence with your patients. So this graph depicts the natural history of untreated HIV infection over time in an individual. Let me orient you. In blue, the line represents the individual's CD4 count in peripheral blood, and in red, we see the HIV viral load in blood. During the early phase of HIV infection, the first few weeks, termed acute infection, we see a very high spike in HIV viral load and an associated decrease in CD4 count that rebounds somewhat, but not generally up to pre-infection CD4 count levels. After that equilibrium is reached and a viral load set point is achieved, there's a period in what this slide is termed clinical latency over several years. I think that term is somewhat misleading. Because while a patient may have no clinical signs of HIV infection, they may still have signs such as nonspecific symptoms, fever, weight loss, adenopathy. And what we know more importantly is during that time, there is significant and potentially irreversible damage going on both to the immune system as well as to other organ systems in the body. So while HIV may not be clinically apparent, there still is damage going on in the individual as a result of HIV infection, and this is the damage we are trying to prevent with HIV antiretroviral therapy. Over time, however, untreated HIV does progress, CD4 counts do decline, and over time the viral load begins to increase. When those things happen, individuals begin to manifest more symptoms of HIV and may be at risk for opportunistic infections and death, and that's the period that we refer to as clinical AIDS. So with that understanding of the natural history, we now have the tools available through antiretroviral therapy to interrupt that natural history and really dramatically change the course of HIV infection in an individual. So our goals for initiating antiretroviral therapy are first to reduce the HIV-associated morbidity and prolong the duration and quality of survival as a result of HIV treatment. Secondly, we hope to restore and preserve immunologic function in the individual for long-term benefit. And our goal, how we measure that, is through maximal and durable suppression of plasma HIV viral load. And we also know as a corollary to this that when we suppress viral load optimally in an individual, we also prevent the likelihood that that individual will go on to transmit HIV to uninfected sexual or needle-sharing partners. The advancements in the field of HIV have been really dramatic over the last 15 years. We've seen HIV go from a uniformly fatal disease to now we're thinking of it much more like a chronic infection that we manage over the duration of someone's life. Here we see data from the NA Accord cohorts looking at survival in North America and people living with HIV. And you can see over relatively short periods of time, dramatic increases in survival. These data highlight that for a 20-year-old who initiates ART therapy in the year 2006 or 2007, that individual can expect to live to be 67 years old, and that's compared to an overall population life expectancy of nearly 79 years. Updated data from this cohort indicate that those trends are actually continuing to improve, and for some subpopulations, the life expectancy is actually equal to that of an HIV uninfected individual. Importantly, there are still strides that need to be made, as there are negative effects of gender, race, HIV risk group, and importantly, CD4 count at ART initiation. All of these things indicating we still have a lot of improvements to make, and we need to be initiating people at higher CD4 count to get the optimal benefit of antiretroviral therapy. These same benefits are also seen globally. These data are from Uganda, where a 20-year-old, again, who initiates ART can expect a life expectancy of 46.7 years compared to a population life expectancy of 61.6. And again, these results are affected by gender and importantly by CD4 count. So if we diagnose HIV early, initiate ART at high CD4 counts, we're able to preserve the immunologic function and decrease the damage done by HIV over time. And that translates really to a significant survival advantage to the individual. I want to spend a few moments here on this slide where I've really tried to highlight a lot of data that have led us to believe currently that ART is most beneficial when initiated early. Thinking about the option to delay antiretroviral therapy, there are concerns around ART drug toxicity, the need for safety monitoring and drug costs, and then also preserving various options for antiretroviral treatment so individuals don't run out of treatment. People who are concerned about early ART worry about the development of drug resistance that might limit an individual's options over time. And then we all know that it's very difficult for people to adhere to antiretroviral regimens. And if we put them on earlier, we're asking for longer periods of adherence. So those concerns led people to think that it may be reasonable to delay antiretroviral therapy. However, with the currently available therapies, a number of studies and fields of work have really demonstrated the overall benefits of early antiretroviral therapy, benefits for the individual and benefits for a population. So on the early ART side, the currently available ART regimens are more efficacious, convenient, and tolerable compared to prior regimens. So some of the concerns about regimen complexity and tolerability are less of concern with the modern treatments. We also not only have better treatments, we have more treatment options. So people who do experience virologic failure or have drug resistance will have the opportunity to have fully virologically suppressive regimens for the most part. And we also learned that contrary to the concerns, that initiating ART earlier actually leads to a lower development of drug resistance over time. Early ART tends to be tolerated better, and people have fewer toxicities when they initiate ART at high CD4 count. And in addition, I mentioned before that we're worried not only about the effects on the immune system, but also the effects of the virus on other organ systems. And we recognize that uncontrolled HIV viremia is causing damage over time to other organ systems, in particular cardiovascular system, neurologic system, the central nervous system, can drive bone mineral density loss, as well as damage to kidney and liver. So all of these things are going on during the period of uncontrolled viremia. And right now, our understanding is the best way to prevent those damages from happening is to control the viremia. I showed you previously that ART dramatically increases the lifespan of the individual and will also decrease HIV transmission. So in balance, all of those factors really do favor early antiretroviral therapy initiation. So how have the guidelines changed to reflect that? Let me first focus on U.S. guidelines with the Department of Health and Human Services. The question of what to start and when to start is an age-old question in HIV ever since we've had effective therapy. And the pendulum has swung back to early initiation. The most recent iteration of the DHHS guidelines recommend antiretroviral therapy in all HIV-infected individuals. That was my emphasis added there. But I think it's important that we recognize that the guidelines now reflect universal treatment. And this is done for the individual benefit to reduce the risk of disease progression. The strength of the evidence actually does vary by CD4 count, with the strongest evidence being at CD4 counts less than 350. But between 350 and 500, and in fact above 500, there is now consensus that treatment is beneficial for the individual. Secondarily, treatment is recommended to prevent transmission to uninfected partners. So while there is clearly benefit to the individual of ART initiation at any CD4 count, there's also demonstrated benefit to his or her partners. That's true clearly in perinatal transmission, heterosexual transmission, and also believed to be effective at preventing transmission in other risk groups as well. The question in the U.S. of what to start when it's time to initiate ART is a long discussion and a very nuanced one. But in general, the guidelines recommend 4 different regimens currently as options for the preferred ART initiation. And those include regimens that are NNRTI based, protease inhibitor based, and integrase inhibitor based. The individualization of those regimens depend on your patient profile, as well as comorbidities and other factors that you'll consider. It's important to recognize, too, there's a long list of alternative regimens. So for people who may be better suited to one of these regimens, the guidelines do provide options for alternative ART initiation. Globally, the World Health Organization guidelines mirror those in the United States largely, with some important changes. These are the most recent 2013 updates to the World Health Organization guidelines and recommending when to start ART in global settings. The WHO clearly indicates ART is appropriate in all individuals with WHO clinical stage 3 or 4 disease, regardless of CD4 count. In individuals who have clinical stage 1 or 2 HIV disease, ART is indicated at CD4 counts below 500, and with preference given to individuals with below 350 CD4 count. In addition, special populations are highlighted here. Individuals with concomitant tuberculosis, ART is clearly beneficial in those with active TB disease, regardless of CD4 count. Same is true with hepatitis B co-infection and severe liver disease. And the WHO guidelines now also acknowledge the importance of using ART as a prevention tool in serodiscordant couples. And the WHO guidelines do suggest that we provide ART to HIV-infected partners who are in serodiscordant relationships. Which treatments to start in the WHO guidelines vary slightly from U.S. guidelines. In general, the WHO guidelines are NNRTI based, and you can see their preferred regimen here of tenofovir with either lamivudine or emtricitabine and efavirenz, with some alternate regimens listed, as well as some special populations. So with that in mind, I think it's important to take a moment to highlight ways in which we might approach ART initiation in a patient-centered way. It's clear that the key to successful ART treatment in the long term is really patient adherence. So getting patients involved in the decision-making process around when and what to initiate ART is really beneficial in the long term. Building a trusting relationship with your patient with open communication will give you the opportunity to understand your patient's perspective and allow you to make better treatment decisions in partnership with your patients. I think it's really important from the beginning to proactively identify potential challenges to ART adherence and to try to address those as much as possible. Those will vary quite a bit by individuals and in different settings. But some things to think about will be the individual's schedule, whether that's work or school schedule, travel schedule, their meal schedule. Certain ART will require different food and fluid requirements. So understanding that will be helpful. In many populations, mental health, substance use, and housing instability are really quite significant barriers to adherence. And to the extent possible, addressing those proactively and trying to stabilize those factors for patients will help them be successful in the long term. Food insecurity, medication insecurity, changes in insurance status, all of those can pose threats to ART adherence, and the astute practitioner needs a therapeutic alliance with their patient so that those concerns can be communicated and addressed proactively. In addition, with the number of different regimens that I've highlighted for you, it's important to pick ones that are convenient to a patient's lifestyle and will minimize the chance for a patient to experience toxicities. Again, I think that talking about that up front with your patient will be beneficial in the long term. And then importantly, at every visit subsequent to ART initiation, it's important to talk about ART adherence, assess someone's tolerability of drugs, their treatment, adherence, and try to use standardized and reproducible tools to the extent possible. So in summary today, I've talked to you a little bit about the importance of initiating antiretroviral therapy in all individuals infected with HIV infection. We've recognized that ART treatment has really revolutionized the care of individuals living with HIV. And for most people now who have HIV infection, their HIV can be managed as a lifelong chronic condition and therefore requires lifelong treatment as best we know now. Modern